All right. Should be streaming now to Facebook and YouTube. And yes, I see people joining. Let me just confirm. Lovely. There we are. Okay. Hello, everybody. Let's go ahead and start the show for you. Got a few people joining early. Love to see it. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program. My name is Rain Bennett. I'm your host this episode and every episode. I'm a filmmaker and a writer by trade, and I've been working alongside CCF and LACNet's. CCF for almost 15 years now, LACNet's in the past few. And over the course of that time, decade plus, we have created, I've lost count how many videos, hundreds of videos, I would say, especially if you include live video series like the one you're going to watch today, but patient-centric documentaries, treatment-based videos, conference and event videos, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That's what we're here to do. Now, the value that I see very clearly in this show is twofold. One, the information and hopefully answers to some of your questions that you'll get from our guest expert today. And two, the shared experiences and shared stories from within the community, the Luncheon with the Experts community. So you might see people in the chat already saying hello and where they're signing on from, Virginia, etc. Canada is always strong in the house. Listen, if you are new to this journey, new to this show, new to this community, embrace the community. I assure you they will embrace you back. It is so incredible how strong and supportive this community is, and that's caregivers, support group leaders, doctors, and specialists, as well as patients. So introduce yourself, tell us where you're signing on from around the world. We always like to see how far the program reaches, and you may have questions that are for people in the audience, and they'll answer them. So super supportive. So I really encourage you to show up here every week if you can. Folks at home that are regulars, which we have a lot of those, if you see someone or notice someone that's not here, you can tag them in the comments, let them know the show is going. We are currently going to Facebook and YouTube, so we've got every week we have more and more people growing from the YouTube channel, which I love to see. And by the way, I have a quick announcement about that. I always say, if you want to find any of the videos that we've done about Luncheon with the from Luncheon with the Experts, or any of the documentaries we've done, they all exist on Facebook under the videos tab, same on YouTube. We just got notice that Facebook is going to start kind of sunsetting or offloading rather the live videos after a certain term, 30 days or 90 days, which they haven't historically done. Maybe they're just accumulating a lot and they can't store them anymore. So we'll find a solution for that because I think it's still helpful. You all let me know if you actually do go back and look at some of the old episodes. We often refer to them because some might be around a more specific topic. And I want to make sure that we save those for you, which might just be a manual process of downloading and re-uploading. And we will absolutely do that. So go ahead and start sending in your questions. Before we get started, I have a graphic I'm going to show. I want to thank this month's sponsors right there. Big thanks to our presenting sponsors. We could not do this show without them, so appreciate the support of everybody, especially the support of you all at home, and the support of our guests. Speaking of which, I am excited to welcome back to the show for the first time in a couple of years, Dr. Nitya Raj. Dr. Raj, how are you?
Good. Thank you for having me again. I'm excited to be here.
Absolutely. So for those that may have missed your last episode, you asked me earlier before we started recording when that might have been. I think it might have been 2022, which, surprise, is going on 3 years ago now, which is wild. But I know it's insane. For those that might have missed that or might not be familiar with your work, I alluded to a moment ago this NET community. What's the role that you fill in this NET community? Where do you work? What do you do? Who do you serve?
Absolutely. So I'm one of the GI oncologists at Memorial Sloan Kettering Cancer Center. My primary focus is in the clinical care of patients with neuroendocrine cancers. So in my clinical practice, I primarily care for patients with neuroendocrine tumors and some other rare endocrine cancers. And I do a little bit of colorectal cancer as well as pancreas and biliary cancers as well.
Got it. Lovely. Folks, just a little bit of guidance and best practices. I know I mention this every week if you're a regular, so you probably know the drill. Very, very hard for us to field super case specific questions in this format, especially if Dr. Raj is not your doctor. So small generic chunks is going to be the best way to get the answers towards your questions. There's no limit, so you can ask follow up questions. So ask one little chunk at a time. If Dr. Raj feels like she needs more clarification, which sometimes we do, we'll ask you that. And if you're still on the call, you can provide that in information. Just mention that you're referencing the question you had earlier. But in general, I think a lot of people think the more information they give and more specific they are, the easier it is to get to a specific answer. But it's just really hard to field that type of question in this environment. But go ahead and start sending them in now. And we will be fielding them as soon as we can. I saw someone, Vicky, signing on from Las Vegas. Hey, Vicky, good to see you. And if you are gambling right now, put 20 on black for me. Lots of people all over the place. Questions rolling in already. Catherine's, please save the Lunch and the Experts videos. Yes, we intend to. Okay, so we're going to try to get to all the questions that we can, and we've already got some rolling in, so let's go ahead and get to it. Shane, hey Shane. Shane is one of our regulars for sure. What is your protocol for scanning during PRRT? What are you looking for in these scans as a follow-up question?
Yeah, so that's a great question, Shane. And I think that as we use more and more PRRT, those of us who have a primary focus in neuroendocrine are coming together and thinking together about how we should be doing imaging during the course of therapy. So for those who may not be as familiar with this treatment, PRRT is a special type of radiation therapy. The way I tend to describe it to my patients in clinic is it's almost a form of IV radiation therapy that is going to be going through the body and binding to that somatostatin receptor that is on many neuroendocrine tumors. And so the way that the PRRT works is that it's going to bind to that receptor, it's going to internalize into the cancer with the expectation that it's going to then kill the cancer cells. The thing about PRRT that is different than a lot of other types of cancer therapies that we give is that the effects of the radiation are over a lengthy period of time. And so what that means is that it can take time for us to see the effects of it on imaging. So kind of Shane, back to your question, as some of you may know, the way the therapy works is it's over a period of 32 weeks, and you're going to be getting a radiation treatment every 8 weeks and doing 4 of those radiation treatments in total. So our practice at Memorial is that we will follow our patients very, very closely clinically through the course of therapy. And so we're going to be keeping a really close eye on your blood work and assessing your symptoms and your tolerance to the therapy. But if someone is actually tolerating the treatment well, we sit tight and we don't do any imaging during that 32-week period of time. Rather, what we do is we typically wait 2 to 3 months after that last dose of the PRRT. And at that point, we'll repeat imaging. And our standard practice at Memorial is to do a dotatate PET scan and either a CAT scan or an MRI at that time to reassess the cancer. So, if you're doing well through the PRRT, we really try to hold off on imaging because it can be hard to see the effects of the radiation and it can be confusing sometimes to interpret imaging results during the course of therapy. Of course, if someone we're worried is not tolerating the therapy well, or maybe is having side effects, and we're a little bit concerned that the cancer may not be responding very well, then of course we will do some imaging while someone's in the midst of treatment. But apart from that, we really try to hold off on imaging during the course of the PRRT.
Got it. Thank you. And a quick follow-up question. Can you talk about the idea of pseudo progression after PRRT and how this is determined versus actual progression?
Yeah, that's a great follow-up question. And so what pseudo progression is it's that on imaging, it looks like the cancer is growing, but it's actually not growing. It's sort of like an inflammatory response to the therapy that then will kind of settle over time. So this is a phenomenon that was sort of initially described in a type of treatment called immunotherapy, which is another type of cancer treatment we use as oncologists. And it is something that we can sometimes see in PRRT. So like I was mentioning, we'll do that first set of scans 2 to 3 months after you finish up the radiation therapy. And sometimes what we may see on the scan is that the cancer looks larger. Now, If I see that, but someone is otherwise feeling well, really has no other symptoms, then we also sit tight in that situation because there's a real possibility what we may be seeing is actually pseudo progression. And then we'll repeat another set of scans in about 2 to 3 months. And on that set of scans, typically, on that second set of scans, if it's pseudo progression, what you'll see is that the disease starts to stabilize or it even starts to shrink. So pseudo progression can be tricky because, um, yes, sometimes when we see growth, it could be that the cancer is really growing, but it's also very possible that it's just sort of the inflammation from the treatment that you're seeing on imaging making the cancer look larger, but it's actually a treatment response. So again, that's why that clinical exam and really just sitting down with your patient and just seeing how they're feeling, that will guide our decision on whether we're going to sit tight a little bit longer or we feel that there may be something more active going on in the cancer.
Got it. Thank you. And thanks for your questions, Shane. Both questions. Moving on, and our numbers are growing quickly. Love to see that. By the way, folks on YouTube, don't be shy. Feel free to ask questions. We don't want to let the Facebookers dominate there. We love to hear from you. I do see those questions as well from those coming in on YouTube. Next question from Josh. Josh says, can NETs be hidden in the adrenal gland? I have a nodule that I'm being told there's nothing going on with. All tests from the endocrinologist said blood tests are normal, except a little bit high cortisol. No NETs found. However, I'm symptomatic yet except for positive REN blood test.
Yeah, that's a great question. Nets can very, very rarely arise from the adrenal gland. However, sort of in the absence of clearly seeing something on imaging, we would, even with a positive REN test, which is a test that's kind of being used, although is not really incorporated into our national guidelines as sort of a diagnostic modality to identify a neuroendocrine tumor. I would be really, really looking for other causes of sort of some of the changes that we're seeing, and kind of doing further evaluation, likely with an endocrinologist in that setting.
Got it. Appreciate you, Josh. Richard says Dr. Raj is the best. She's my net expert. Love to hear that.
Hi.
If someone has had 4 PRRT treatments, what would determine whether or not 2 more would be warranted?
Yeah, so the way PRRT has been studied pretty rigorously now, in the prospective NETTER-1 study, was really a defined course of 4 treatments. And so as standard practice, we really only do up to 4 treatments of the radiation therapy. We don't typically push beyond, even if we feel that someone is tolerating well, or it might be kind of theoretically could be beneficial to give a little bit more. We'll do 4 treatments. We'll reassess by imaging. If the cancer is responding after those 4 treatments, then we stop and we watch. Now, in that setting, sometimes when we get a nice response to the radiation therapy, and there's a lot of work going into this now, and there's some clinical trials in development and that are active and open now. We're looking at the possibility of what we call re-PRRT, or a second course of treatment with PRRT. And that's certainly something we do at Memorial. And in that setting, we may consider a few more doses of the radiation therapy, but kind of in your first course of the PRRT, we would never go beyond the 4 doses of the PRRT.
Got it. Sticking with the PRRT, Jordan over from YouTube. Thanks, Jordan. I'm undergoing PRRT now. What hold on long-acting octreotide do you use for your patients prior to the radioisotope infusion? This question seems controversial.
Yeah, that's also a great question. And the theoretical concern here is that if you take the octreotide injection just kind of soon before the radiation therapy, that you may block those receptors that the radiation therapy is going to then bind to. So our practice at Memorial is to give the octreotide injection at least a month before. the dose of the PRRT. And then if someone is kind of staying on their octreotide injections throughout the course of the PRRT, we give it to them right after they get treatment. So like, for instance, if you got PRRT today, we would bring you in like tomorrow or the next day for your octreotide injection. You can even do it at the end of the PRRT on the same day. You just don't want to give it like right before. So we give like a 4-week window between the injection and when you get the radiation therapy.
Got it. Thanks, Jordan. Hopefully that helps. Next question comes in from Doug. Have you experienced Opdivo to be effective on 7 centimeters plus tumors? And if you can't be that specific with it, maybe we can talk about, where and how you have seen it be effective.
Yeah, so Opdivo is a part of a different class of drugs called immunotherapy. And so what immunotherapy drugs are they're drugs that activate the immune system with the whole idea that your immune system is going to recognize the cancer as foreign and then sort of attack and kill your cancer cells. So, there's been a lot of work over the past decade plus on immunotherapy in various types of cancer. As a neuroendocrine community, we have done a ton of work and a lot of clinical trials looking at immunotherapy drugs, including Opdivo and some of the other similar classes of immunotherapy drugs in neuroendocrine tumors. Unfortunately, in the studies that we've done, we just haven't seen very much activity for these drugs in their current state. So coming back to the question, for a neuroendocrine tumor, size is really not an important factor in deciding whether or not a drug like Opdivo may be beneficial. There are certain types of additional kind of genetic testing that we can do, which can sometimes identify other markers that may tell us immunotherapy may be a good treatment to consider. But for kind of just, a treatment option for well-differentiated neuroendocrine tumors of sort of a specific size, Opdivo is not a medication I would look to.
Got it. Thanks, Doug. Hopefully that helps. Catherine says, how many of your patients with carcinoid syndrome go on to develop carcinoid heart disease? And what do you do for a carcinoid syndrome patient that develops chest pain over time?
So, carcinoid heart disease is a rare complication of neuroendocrine tumors that are functional or hormone secreting, specifically those neuroendocrine tumors that secrete the hormone serotonin. And so, what happens is over time, that serotonin hormone will actually deposit on the valves in our heart, specifically in the right side of our heart, and make them very, very, very stiff. So, carcinoid heart disease is very, very, very rare. Um, you know, the hormone secreting neuroendocrine tumors to start with are pretty rare. And then even amongst those patients that have serotonin secreting neuroendocrine tumors, you're just talking about a few percent of patients that develop the complication of carcinoid heart disease. The key when you're caring for patients with neuroendocrine tumors is to one, do that evaluation early and try to sort out whether there is a serotonin secreting component to the disease. And if there is, then we're more proactive about starting therapy, even if someone doesn't really have any symptoms, just because we want to get the hormone levels down, decrease the chance of the serotonin floating around in the body. And then two, you want to keep a really close eye on the heart in those patients. There's not a standard practice, and this is very, very variable from institution to institution. At Memorial, we will do heart ultrasounds once a year just to keep an eye on the heart valves. Obviously are very thorough in our clinical exams when we see you in clinic, looking for any signs that the heart valves may not be working very well. And if you see any evidence of heart complications from neuroendocrine tumor, then a really early referral to cardiology and typically a cardiac surgeon, because they often need to be involved to help us take care of the heart in these situations. Chest pain is not typically a symptom that people will present with that have carcinoid heart disease. So it's very rare for someone to have chest pain as their presenting symptom. More commonly, you'll start to see symptoms of heart failure because the heart valves aren't working well and the heart just isn't pumping well.
Got it. Thank you, Catherine. Angela says, are there any prevention studies or advice for someone with gastric neuroendocrine dysplasia?
So there aren't any sort of prevention studies out there. I think by gastric neuroendocrine dysplasia, I'm assuming that you're speaking to perhaps having a very, very small neuroendocrine tumor, maybe identified and removed in the stomach. And in that situation, the key is really to do really close follow-up actually with a gastroenterologist. They'll do periodic endoscopies and just take a look at the stomach. But there aren't other preventive strategies there.
Got it. Thank you. Thank you. Hey, Sasheen says, if debulking surgery must be delayed in the setting of carcinoid syndrome, what other options are available in the meantime to keep functional tumors suppressed pending surgery? High doses of sandostatin are obviously not effective. Recent surgery for carcinoid heart disease. Thanks.
Got it. So, if for whatever reason, they think that surgery, it's not the right time to try to debulk the tumors, that's sometimes a strategy we'll actually use to keep the hormone levels under control. Then we have to go to some of our other treatments that we have for the disease. Because the whole idea is that if you can manage the cancer, if you can get the cancer shrinking a bit, then you're going to decrease the hormone levels. So, for like a small bowel neuroendocrine tumor, if you're not thinking about a procedure per se and you can't use your injections, then you may be looking towards some of your oral treatments like everolimus, cabozantinib, which is a medication that we're all hoping is going to get approved in the near future. Rarely and less commonly, sometimes we're looking to our chemotherapy drugs, but sometimes we'll use some of those types of treatments as well.
Got it. Got it. Michael says, can a patient with peritoneal carcinomatosis rather, be treated with PRRT?
Yeah, so for sure. So patients with peritoneal carcinomatosis can be treated with PRRT. One of the things we're learning and was not appreciated very much when the NETTER-1 study was done, that was the big study that led to sort of the FDA approval of PRRT, is that in people who have peritoneal carcinomatosis, which, the way to think about it is it's sort of cancer studding a lining that we all have that sort of sits on top of our abdomen and pelvis, is that because of the inflammation from the radiation therapy, one of the side effects that we sometimes could struggle with is actually bowel obstructions. And so the idea being that the inflammation causes the in the peritoneum, in the disease in the peritoneum, causes the bowel to almost kink on itself and causes these little obstructions. And so it's something that we are seeing more commonly in patients with peritoneal carcinomatosis that we didn't really see in NETTER-1. And so that's not a reason that we don't give patients PRRT. We still certainly offer it to patients with peritoneal carcinomatosis. Sometimes if there's a lot of disease there and we're nervous that there's a high risk for a bowel obstruction, then sometimes we'll give a short course of steroids after each of the radiation treatments just to calm down the inflammation. We just keep a close eye. We have a low threshold if someone is having any symptoms after treatment to bring them in and get them checked out. But it's not a hard stop that if you have peritoneal carcinomatosis, you can't get PRRT.
Got it. Got it. And sticking with the PRRT theme that we have seemingly developed, Melissa says, how might PRRT initially affect the functioning tumor hormone output, especially in the case of gastrinomas?
Yeah, so sometimes what we can see with PRRT is you can see the hormone levels rise before they fall. So you just have to be very thoughtful when you give patients these medications that their symptoms from the hormones may get worse for a period of time, but then gradually will start to get better as the radiation takes more effect in the symptoms. So again, it's not a reason that we wouldn't give the therapy to someone in hormone secreting disease. In fact, PRRT can be an excellent therapy to control kind of those hormone symptoms in patients with hormone secreting neuroendocrine tumors. You just have to be mindful that there can be an initial escalation of symptoms before things get better. And we'll use like kind of our other supportive medications to manage it in that situation, depending on what the hormone is that we're dealing with.
Got it. Thank you, folks. If you joined us a little bit late or just joined us recently, this is Luncheon with the Experts. We are here with Dr. Nitya Raj. And I said, I have a correction to make in the beginning. I said this is a Carcinoid Cancer Foundation and LACNet's program. Well, folks, there's been a rebrand, and I'm just so used to saying this that it's second nature to me. LACNet's is now officially the Neuroendocrine Cancer Foundation. You can probably see that in the comments, and you probably are well aware of that, but I just wanted to bring attention, and I will correct my routine behavior patterns that I have developed. But yeah, special shout out to the Neuroendocrine Cancer Foundation. That's very, very exciting and continues to show their growth. So that's great for all of us. Let's get back to the questions. We've got just a little bit more than 30 minutes, so plenty of time to get to your questions, and the questions have been awesome so far. Keep them coming. Sticking with PRRT, how often does PRRT lead to low blood counts, or more critically to MDS, or contribute to shingles or other viruses due to lowered immunity?
Yeah. So as we use more and more PRRT, of course, we're getting more and more information and data on potential side effects of the therapy. One of the more common side effects that we can deal with PRRT is lowering of the blood counts. So it's something where we'll often see the blood counts sort of go down and gradually come up. It can be very, very variable from person to person what that risk may be. And I think the biggest factor that's driving that is what the prior treatment history is. So, what types of therapies someone's gotten in the past. In someone who's really not had many therapies and is moving towards PRRT early in their treatment course, generally we don't have as many issues with the blood counts. However, in someone who maybe has gotten a few other cancer therapies or maybe even chemotherapy before they go to the PRRT, then sometimes we do deal with more issues with the blood counts and kind of have to work through that. In terms of the risk for MDS, which is kind of a more long-term damage of the bone marrow from the radiation therapy, which can rarely then turn into kind of a cancer of the blood, like a leukemia, very, very rarely. So it's something we have to keep a really close eye and mind about when we're recommending these therapies. The risk is felt to be on the order of a few percent with PRRT, so very, very, very low. That being said, as we treat more people and we're appreciating that, some of the people have gotten other therapies before or after, we're seeing that with some of our chemotherapy drugs and PRRT, if someone's received both of those types of treatments, that risk of MDS can be a little bit higher, like even in the 4 to 5% range. So, of course, this is what we talk about when we sit down and we talk about what the treatment options are, what the potential risks are, what the potential benefits are. All of us who care for patients who are getting PRRT, we're keeping a very close eye on those blood counts during the course of therapy, checking them at least monthly, if not more often, if the blood counts lower a little bit during the treatment. But these are things that we have to be very thoughtful of when we recommend PRRT to people and when people are going through PRRT.
Got it. Thank you. A couple questions about histotripsy, which always comes up these days. Richard says, does MSK perform histotripsy? And if so, have you seen any success with nets on the liver? I've heard yes and no in other podcasts and presentations.
Yeah, histotripsy. I feel like I talk about that in pretty much every clinic now.
Totally.
And so for those who may not know, histotripsy is a newer therapy which was recently approved kind of across the spectrum of liver tumors, so cancers that are in the liver. It's tricky in neuroendocrine because we have a lot of really, really good, what we call liver directed therapies, where we've done really rigorous studies in neuroendocrine tumors specifically to demonstrate the benefit of certain types of liver directed procedures, specifically embolization. And so, histotripsy, for better or for worse, has not necessarily been specifically studied in neuroendocrine tumors. And so it makes it a little bit tricky for us to sort out where it may play a role in kind of the tools that we have and the therapies we have to treat the liver. So, we're thinking very thoughtfully at MSK about how we should maybe use histotripsy and what's the right way to use histotripsy. It's a treatment performed by an interventional radiologist. Kind of, we're doing it now at MSK. It's not typically what our preferred approach is to treat neuroendocrine tumor when it's in the liver. There's some select situations where it may be something that interventional radiologists may recommend based on the location of where a liver tumor is in the liver. But right now, it's definitely not a therapy that is our first choice if we're thinking about a liver-directed procedure for a neuroendocrine tumor.
Got it. Thank you. And Amna, let me know if that addresses your question as well. We had another one about PNET, liver mets. I have a question from Michael. Is NF1 directly associated with NETs? NF1 being neurofibromatosis type 1.
Yeah, so I mean, we can see, so rarely there are genetic changes in a family that can predispose someone to a neuroendocrine tumor diagnosis. And NF1 is kind of one of those genetic changes which can be associated with the development of neuroendocrine tumors. Now, having, an NF1 change does not necessarily mean that you are going to develop a neuroendocrine tumor, but it can be associated with the development of neuroendocrine.
Thanks, Michael. From Sarah, what is recommended from your perspective when there is some progression of growth of a tumor and a choice has to be made to add another treatment to a regular regimen of lanreotide injections? 2 more PRRT for previous in June 23 or everolimus. What should I consider when trying to decide, which is ultimately the crux of the question, I think.
Yeah, and this is a clinical dilemma we struggle with as the oncologist ourselves when we're trying to make a decision with what's the right choice. One of the most amazing things about caring for patients with neuroendocrine tumors and coming into this field in the past decade is that, in the past 15 years, we've had so many therapies developed in this disease, more therapies for neuroendocrine than any of the other GI cancers that I care for. But the challenge that we have now is while we have the therapies, we're struggling with what we call the sequencing data. So, like, what should I give first, second, third, fourth? And so we rely a lot on sort of the behavior of an individual's neuroendocrine tumor to make kind of some decisions about what therapy do we go to next. So, kind of in specifically referencing the question that was asked, it sounds like there was a nice response to the PRRT originally because it's been, a few years now and you're starting to see a little bit of growth. Often the way I approach this is that if it's just kind of in one or two areas or it's very isolated, sometimes I will consider a drug like everolimus first, just because it's kind of nice. It's a pill, can kind of put the brakes on things. It's a little bit less intensive than the PRRT per se, and then save the PRRT again for a little bit later. Um, Honestly, though, there's not a right answer. Sometimes it's just sort of a shared decision between my patient and I, where we sit down and we talk about the different options. Some people have a preference to go in and get the PRRT and just kind of be done after a few treatments. Others will have the preference to go on an oral pill. Others might say, I want to do, like, if it's just a little bit of growth in the liver, I'd like to do like an embolization. So it sometimes just kind of comes down to a shared decision in terms of what might be better for the quality of the patient as well.
Got it. Thank you, Sarah. From Susan, how often do you do scans on someone with a well-differentiated small PNET? No biopsy has been done at this point.
Yeah, so for the really, really small ones, who who are usually often seeing one of our surgeons, although sometimes we see them in medical oncology, that on imaging look like they're a neuroendocrine tumor. Our practice at Memorial too is to just kind of watch them. We often don't do a biopsy. Usually about every 6 months is what we're doing in terms of imaging. Not any more frequent than that. And if we do it on the 6 month interval for a period of time, we're not seeing much change, then we'll gradually space it out to 8 months, 10 months, kind of get to a year. And so the soonest, though, that we would do scans is about every 6 months.
Got it. Thank you, Susan. Question I haven't had in a little while from Christina. Do you have any information about the COVID vaccine or COVID effect over the growth of nets?
Yeah. So we don't. I think all of us are curious and wonder if there could be any effects of like the vaccination on cancer in general, not specifically. I mean, I will say to hopefully to try to give comfort to people, the technology that was used for that vaccine, you know, we do not believe would increase the risk of cancer. So amongst the scientific community, we don't think that the COVID vaccine is will result in increased cancer, like will not cause cancer. So when I'm asked this question, I feel very comfortable saying that if someone developed a neuroendocrine in the past few years, that it's not related to the COVID vaccine. That being said, we don't have that answer yet. I think there's going to be a lot of work going into this, but it's going to take decades of really following people after vaccination to see if there's any association with the COVID vaccine and the development of any type of cancer, whether it's neuroendocrine or something else.
Got it. Thanks, Christina. Appreciate you being here. Also, want to say hello to Alita from Namibia. I think that might be the first time I've seen you here, Alita. So welcome. Appreciate you being here. Let me know if you have any questions. Dun, dun, dun. From Amna, post-Whipple PNET, non-functioning with liver mets, stable with lanreotide for the last year. Follow-up is 3 monthly with MRI. The question is, can we push to 4 months with CT scan? I'm sure there's a lot of variables to consider, but any thoughts for Amna?
Yeah, I mean, listen, when we, remind me, the disease is in the liver, correct? Is that what you said?
Post-Whipple PNET, non-functioning with liver metastases.
Metastases, yep. So yeah, so in someone that I meet who has metastatic or more advanced disease that we have on the somatostatin analog or even other therapies, but in particular the somatostatin analog, usually my practice is I'll initially do a scan at 3 months. After 3 months of the injections, just make sure things are stable. If things are stable, we start spacing out right away. So my next step is to go to 4 months, and then I go to 6 months, and then we stay at 6 months for a little while. And if that looks good, we go to 8 months and we keep spacing out. So, there are patients that I care for that I've been caring for, a decade or more that are on these injections that now we're doing imaging maybe every year and a half. And we feel comfortable doing that when we see that the biology is that the injections are controlling things nicely. So I would feel really comfortable spacing for sure.
Got it. Excuse me. From Matt over on YouTube. Hey, Matt, what order of treatments would you recommend for lung net with bone metastasis? Primary lung has been removed, but bone mets showing growth and progression. Somatostatin, PRRT, any thoughts?
Yeah, so neuroendocrine tumors that start in the lung are rarer, and so less common, although we certainly do see them. And they fall under the bucket of what we call foregut neuroendocrine tumors. So foregut neuroendocrine tumors include neuroendocrine cancers that start in the lung, the stomach, the pancreas, the duodenum. And so we do kind of use similar types of therapies for that whole group of cancers. One of the trickier things about neuroendocrine tumors of the lungs is that we believe that they do have that somatostatin receptor on their surface. That's the receptor that the PRRT and the lanreotide or octreotide target, but sometimes we don't pick it up as well on the dotatate scan. So usually for someone with a diagnosis of a neuroendocrine tumor of the lung, my first step is I will do a dotatate scan and I will see if I'm seeing that receptor. If the receptor is there, my first choice really is to use the octreotide or the lanreotide. If the receptor is not there, um, often I will still try the injections for a few months, and like we mentioned with the just the past question, I'll do a repeat scan in three-ish months and just kind of see if things are staying stable. So I will often try the injections first before I jump to some of our other therapies. But if the dotatate isn't clearly showing the receptor, we get a little bit less excited about using the PRRT just because the side effect profile is much higher for that treatment. And sometimes for the lung nets, we'll move to other drugs like everolimus, cabozantinib, Temodar-based chemotherapy as some of our choices.
Got it. Thank you. From Vivian, following PRRT that halted tumor growth and lowered serotonin and 5-HIA levels, with ongoing lanreotide and Zermello, what addresses frequent episodes of hypotension and hypoglycemia?
Yeah, so that's tricky because it sounds like there may be a few hormones contributing to what's going on there. Um, you know, the injections in the Zermello are really trying to target that serotonin and keeping those hormones under control. Um, Hypoglycemia is a little bit of a trickier one because most commonly when we see hypoglycemia in neuroendocrine, it's because the cancer is secreting insulin, but it's usually not very subtle and it's typically in our pancreas primary neuroendocrine tumors. And so we're really struggling with really deep, like kind of low blood sugars. Um, And so that might need a little bit more digging with an endocrinologist just to make sure we're not missing something else that's contributing there. But even sometimes for low blood sugars, we'll add everolimus on as another therapy that can treat the cancer and treat the hormone itself, because one of its side effects is that it causes your blood sugars to go up a little bit. So we can take advantage of that side effect, and also treat the cancer itself.
Got it. Thanks, Vivian. Sasheen says, if it is determined you cannot receive MRI in the future, what do you recommend for surveillance due to MRI restaging, but may not be available due for MRI restaging, sorry, but may not be able to due to permanent pacing wires, but no pacemaker?
Got it. Yeah. So we would do CT instead. So if you can't do an MRI, then totally reasonable alternative option is to do a CT. I mean, what I would like to emphasize is that for surveillance, CT and MRI are your best friends. So those are your best modalities for surveillance. And not the PET dotatate. So the PET dotatate is not the best way to kind of do surveillance if you're trying to do a screen to make sure that there's no evidence of cancer. You really want to use your CT or MRI in that situation. But yeah, if you can't tolerate an MRI, I would flip to a CT scan.
Eileen says, how do you know if you're seeing a receptor? Is there an SUV number that qualifies?
Yeah, so when we do the PET scans and the dotatate scans, when we're looking for that receptor, what you see, what you all I'm sure have seen on your reports, is an SUV, which is kind of akin to sort of what the brightness is on the scan. Now, there's not a strict cutoff in terms of above this number, you're a candidate for treatments that target the receptor. That being said, in general, if we're seeing numbers that are kind of under 10 or like in the 1 to 5 range, we know the receptor's there, but there might not be enough of the target that some of the therapies that target the receptor are going to work to treat the cancer. So, at Memorial, sometimes when we're dealing with that, because the majority of neuroendocrine tumors do have high SUVs on the dotatate, sometimes we'll do a different type of PET scan called an FDG PET scan and just sort of see what the SUVs are on that. And that can give you a sense of whether or not you should consider treatments kind of targeting the somatostatin receptor or pivot to some of your other therapies if you don't think you should target the receptor.
Got it. From Chris, I have numerous tumors on my liver. One possible option is a liver transplant. Just wanted to know your thoughts about this option, or do you recommend trying all other NET treatment options first?
Yeah, so at Memorial, liver transplant is not an option that we typically consider or offer for neuroendocrine tumors. Liver transplant or organ transplant in general has been investigated just kind of in solid tumors that have gone to the liver to see if it's an option to sort of eradicate the disease and cure someone of the cancer. And unfortunately, apart from something called hepatocellular carcinoma, which is a rare cancer that starts in the liver, the data haven't shown a benefit to liver transplant. And so liver transplant's not something that I recommend or sort of offer for my patients because we don't have the data to support it. And so I would recommend using other therapies that we do have the data for.
Got it. Thank you. Another question from Shane. Shane says, has MSK begun utilizing genomic mutations to help make sequencing decisions? So, for example, DAXX, ATRX, MEN1, etc.
Yeah, it's a great question. And it's sort of near and dear to my heart because I've done a lot of work on genetic sequencing and testing in neuroendocrine tumors. That's what I spent the bulk of my fellowship sort of working on, sort of the MSK experience with genetic testing, specifically for pancreatic neuroendocrine tumors. And so, what the data tells us, and obviously since our early work at MSK, there's been a ton of work done at other institutions, and we've all worked closely together to pool our data. We know that there are certain genetic mutations that perhaps may be protective or be associated with better survival, um, in neuroendocrine tumors, specifically changes sort of in DAX, ATRX, MEN1. And then there's some data to suggest that there may be mutations that may tell you that, the cancer may be less responsive to some of the therapies we have, although it's not perfect. So, the way I think about genetic testing, I definitely offer it to my patients with a neuroendocrine diagnosis, especially patients with a pancreatic primary neuroendocrine tumor diagnosis, but really now for anyone with a neuroendocrine tumor diagnosis, because we do have drug approvals that are sort of across the spectrum of cancer. So if you have a genetic change in a specific gene, then we can get certain therapies for that. And so if we find one of those genetic changes, absolutely, then we'll think about some of those unique treatments to treat the cancer. But for neuroendocrine, I do think where genetic testing can help is sort of prognostically. I think that really importantly, people come and sit down with us and they want to understand, I have this diagnosis, you're telling me it's a more slower growing cancer, but really, how long do you think I have to live? Um, or or kind of what does the outlook look like here, and those are important questions that we're terrible at answering, and we don't have the right answers, but sometimes the genetic testing in neuroendocrine can help us a little bit. Like if I see those MEN, DAX, ATRX alterations, we could sit down and say, like, listen, some of these changes we think are good and we think are going to be protective here. And hopefully that means we're going to get really, really good response from the therapies that we have that are going to help you live very long with this disease. And so that's how I think about genetic testing for neuroendocrine.
Got it. Thank you. Appreciate it, Shane. Folks, we have just shy of 15 minutes left. So go ahead and send in your final questions now. Inevitably, at the end of every show, as we're saying goodbye, I get a flood of questions coming in. So don't wait that late. There's also a little bit of lag time, I think, between what you're seeing on the stream and maybe what I'm saying right now. So you might be hearing what I'm saying in 30 seconds, maybe a minute later. So maybe that's the reason why. But go ahead and send them in now. I'm giving here's your warning. We've got a little more than 10 minutes left. Okay. Moving along from Jen. Hey, Jen, when is it best to get medical oncology involved in care after small bowel net surgery has been completed?
Yeah, I mean, I think that for stage 4 disease, even after successful surgery, we're hopefully, I think what Jen is saying is that the cancer was fully removed. I think, it's very reasonable to see the medical oncologist after surgery, just kind of to establish care. Usually in that situation, the medical oncologist and the surgeon who performed the surgery will see the patient together. We typically wouldn't recommend any immediate treatment, but I think it's reasonable to see a medical oncologist early, and kind of be proactively plugged in.
Got it. Tara or Tara, I see a question from you, but I think we might have addressed it earlier with octreotide injections and hypoglycemic episodes. I think we had a similar question. Is that familiar, Dr. Raj?
It is. I think this one maybe is a little
Is
bit
it okay?
different.
Let's try. I think you can see it in the chat box. But can monthly octreotide injections and/or hormones from net tumors cause onset of hypoglycemic episodes?
So very, very rarely we can see kind of like a immediate reflex hypoglycemia. Specifically kind of in patients who have insulin secreting pancreatic or insulin secreting neuroendocrine tumors. Usually those start in the pancreas. So it's something that we have in mind in patients with insulinomas. It's rare though. And it's not a reason that we don't offer octreotide actually to control hormone levels in those patients. But it's not something that we routinely see. So it's not something that typically we're that worried about when we give octreotide.
Got it. From Stephen, how would you advise to test for glucogonoma rash, which I believe I have? I am having this routinely with a dark area in the pancreas, but no pancreas lesions detected, and I'm having a copper dotatate next week.
Well, so a glucogonoma rash is part clinical diagnosis, part cancer and lab diagnosis. So that type of rash is something you can see in someone who has a glucagon secreting neuroendocrine tumor. Glucagon is a hormone that will typically cause your blood sugars to be very, very elevated. And something that we could sometimes see associated with glucagon secretion is a rash. So, I mean, if you've seen a provider who's concerned that the rash that they're seeing may be related to glucagon secretion, then glucagon levels should certainly be tested in the blood. And it's reasonable to undergo a workup for a neuroendocrine tumor, but it would also be important if those sorts of tests come back negative that Stephen, that like you're plugged in with a dermatologist too, and you're looking for other causes of the rash.
Thanks, Stephen. Hopefully that helps. From Matt, a clarifying question regarding surveillance. Was Dr. Raj saying surveillance using CT or MRI versus dotatate specific to those without receptors?
So what I was saying is that what surveillance is that you've had a surgery, or you've had a surgery and there's no evidence of the cancer. And so in patients with a history of neuroendocrine tumors who have undergone surgery that we hope are cured of the disease, surveillance is a period of 10 years where we follow patients after surgery to make sure we see no evidence of cancer. And so in that situation, the national guidelines recommend yearly imaging typically for small bowel neuroendocrine tumors with either a CAT scan or an MRI. But in that situation, that surveillance situation, there's not typically a role for just doing dotatates routinely. The dotatate scan is the only type of PET scan that's going to look for the receptor.
Got it. Thanks, Matt. Appreciate you being here. Next question from Josh is a capsule endoscopy worth doing? I've had all scans, nothing's showing, and I'll be paying quite a bit, $4,500 out of pocket. So obviously that's not super exciting unless there's some confidence there.
Yeah, so sometimes if there's a concern for like if there's really like very good supporting clinical data that someone may have a small bowel neuroendocrine tumor, then it can be very, very tricky to scan the whole small bowel. And so what a capsule endoscopy is it's a test done by a GI doctor where they actually have you swallow like a pill that goes through your small bowel with the idea that it could identify a neuroendocrine tumor. Now, I will say our practice at Memorial is that we don't typically do capsule endoscopies just because if someone really has a neuroendocrine tumor hiding in their small bowel, there's a risk of that capsule getting stuck, which you actually don't want to happen. So our approach in these situations, if we're trying to look at the part of the bowel the GI doctor can't get to with like an endoscopy or colonoscopy or even like what we call a small bowel enteroscopy, if we're really concerned there could be a neuroendocrine tumor hiding, we will do something called a CT enterography, which is a type of CAT scan that can give you good pictures of the small bowel, or even like a dotatate like scans. Sometimes the dotatate can pick up small bowel primaries, but I would be less excited about doing a capsule if the concern is for a small bowel net, because rarely that capsule can actually get stuck.
Got it. Appreciate your question. And we've got time for just a few more. Sarah says, I have mast cells disease and I have fears of having the dotatate scan, fear of a reaction. Are reactions common?
So I think there isn't necessarily a correct answer to this question. I don't think having mast cell disease should necessarily put you at an increased risk of a reaction from a dotatate scan. Now, again, Sarah, I would definitely talk with your doctor about this because they know your case specifically and see if they have any concerns about you doing the dotatate scan. Reactions are pretty rare with the dotatate scan from the tracer. Usually people do just fine. Very, very rarely people can experience kind of, especially for the hormone secreting patients, a little bit of kind of the side effects they may get from the hormones. But all in all, we don't typically see reactions with the dotatate PET scan.
Got it. Thank you for your question. Rudy says, I have nets that have metastasized to my liver, and the primary source, though, is unknown. Would having a colonoscopy provide any insight as to whether the primary is located in the intestine?
So a colonoscopy is going to really just screen the colon. It's not going to really get into the small bowel. Many patients with neuroendocrine tumors, we don't know the site of origin. Sometimes there are tests that the pathologist can do that can give us a hint of whether it started in the GI tract versus outside of the GI tract. But it's not uncommon for us to meet a patient in clinic and not know where the neuroendocrine tumor started. Um, Really, our most helpful tool, if we can't pick up the site of origin on imaging and like the routine imaging that's been done, is the dotatate PET. Sometimes that'll pick up the site of origin. I mean, it's not unreasonable to do a colonoscopy. The colonoscopy is going to be looking at the lower part of the GI tract, and if you know if it was a rectal primary or a colon primary, you should pick that up on colonoscopy. But you're not going to pick up like a small bowel lesion on colonoscopy.
Got it. Thank you, Rudy. Appreciate your question. Dr. Raj, I ask a version of this question every episode because it is kind of an exciting time right now in the space with all the developments that are going on and the things that we're looking into. Is there a certain area where there's a lot of attention right now that you're excited about, that you'd like to see more progress in or with in the net space?
Yeah, and I think I like briefly mentioned to this in response to one of the questions, but I think that what I had mentioned was, we've had so many therapies develop in
Mhm.
neuroendocrine tumors, which is wonderful and gives us so many more tools to treat these cancers in the clinic. But the big challenge for us in medical oncology is the sequencing of the therapies and what I should do for second and third. And I mentioned that only because, and I'm sure many of you maybe have talked with this with your own clinicians. There are a lot of really important clinical trials going on right now that are really asking those sequencing questions. And they're really, really good studies, because it's the question we grapple with as a clinician, like, do I give CAPE-10 or do I do PRRT? Do I do everolimus or do I do PRRT? Those types of questions. And so I would definitely encourage trial enrollment because there's no right answer when we were making these decisions. And ultimately, kind of the data from these studies is hopefully going to give us the right answers in terms of what therapies should I use for second and third. So I definitely would make a plug for the sequencing studies that are going on. I think the second thing that's super exciting, which I'm sure, those here today are kind of aware of, and which I'm very excited about, is all of the work going into the next generation of PRRT. And so, it's so wonderful to have lutetium dotatate as a treatment option to use in the clinics. We're all very, very excited about the potential for alpha therapy, which is sort of what we think of as our next generation of PRRT. And whether that may become, a treatment option for neuroendocrine tumors in the future. And so there's a lot of work going into that. We have a study open in Memorial too. And so I think more to come there. But I think that's probably going to be our next wave of hopefully new therapies in this disease. And then finally, I think cabozantinib, wonderful potential new tool that we have to treat neuroendocrine tumors. We had the cabinet study opened here, and that showed kind of really the excellent data supporting a role for cabozantinib to treat neuroendocrine tumors. So we're all anxiously awaiting, hopefully, approval of that drug. Though it's something that we are all talking with our patients about in clinic now, and thankfully often able to get approval from insurance to give to our patients. So just really another excellent tool to treat neuroendocrine tumors.
And finally, we've got like a minute. What would you say to someone who's recently diagnosed, a new patient in the past week, past month? They're scared, they're confused, they might not know what this disease even is. What's your first bit of advice for that newly diagnosed patient?
Yeah, and I know first and foremost, it's so scary to just get a cancer
For
diagnosis,
sure.
and then you start reading about it a little bit, and you realize that it's sort of a rare cancer diagnosis, and that's extra scary. That being said, I will say that the incidence and prevalence of neuroendocrine cancers are increasing, meaning that as oncologists, whether you're an oncologist at a major referral center or in the community, everyone is getting more and more comfortable, thankfully, caring for patients with neuroendocrine tumors and using some of the therapies that we use. And so I say that in that I think it's really, really important if you get a neuroendocrine tumor diagnosis to make sure that you're plugged in at a bigger cancer center, and at a minimum have a quarterback or kind of an oncologist who has an expertise or focus in neuroendocrine tumor, seeing you and helping making clinical decisions about what might be the right therapies to treat the cancer. But I also think you should have comfort that if you live a very far distance away from a big cancer center, like we can work really closely with an oncologist closer to home, and we can make treatment of this disease as easy as possible, right? Because we want to make sure that the quality is there. And the last thing I want is, for you to be traveling to New York City for all of your treatments if it's really, really far away. I feel super comfortable working with your oncologist closer to home. And I think that model for cancer care in neuroendocrine tumors, all of us have become more comfortable with over the years. And so I definitely think it's very, very important to get into a bigger cancer center and be seen by a neuroendocrine tumor specialist, either as your primary oncologist or as your quarterback. But I also would not want someone to feel that if they don't live near a major center, it means that that type of care is inaccessible, because it's very much accessible and we can work with a local team well too.
Love that. Perfect answer and perfect timing. It is right at the top of the hour. That is our show for today. Dr. Raj, thank you so much for being here, and just the way you explain everything is very simple and easy to understand. So I appreciate that.
Of course. Thank you for having me. It's an honor.
Absolutely. And thanks to you all at home. Of course, as always, we hope this program helped answer some of your questions. I'll reiterate, if it didn't, you can always send follow-up questions to lacnets.org/support line. The site has changed though now, so maybe I need my corrected version in there for the Neuroendocrine Cancer Foundation. And we'll be back in 2 weeks, of course, so you can always join us next time on Luncheon with the Experts to ask those questions. But we appreciate your time, and hopefully this has been helpful to you. Thank you to our presenting sponsors. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.